Don't compare your journey to your wife, your daughter, your friend. Each journey is going to be individual. Each side effects may be very individual too.
Today, we're going to be talking about GLP-1 agonists. I'm sitting down with Dr. Rocío Salas-Whalen, who is a board-certified endocrinologist and obesity medicine specialist, widely recognized as one of the earliest adopters of GLP-1 therapies in the United States. With over 15 years of experience treating thousands of patients, she has helped redefine obesity care, moving the conversation from willpower to science and from stigma to empowerment. So before we dive into GLP-1s, can you define obesity for me?
Definitely. And just to let everybody know, obesity has been classified as a disease since 2013 in the United States by the American Medical Association, but the WHO classified as a disease, obesity, since 1942. So we are lagging a few decades behind. But obesity, we understand now that is not a willpower problem, right? It is not at the full responsibility of the patient. We know that obesity is a chronic, multifactorial disease. So let's talk about those three words. Chronic, meaning that is long term, that is not curable in most cases, right? That's what defines chronic diseases, that they are controllable, but not curable. Multifactorial, that is not only one cause that is going to have somebody develop obesity, right? We can speak about each of the common or the big umbrella causes, which could be hereditary. We know that there is familial hereditary of obesity that not necessarily is a monogenic genetic problem, but it could be epigenetic, meaning that there's different types of genes that can be passed through generations. We have hormonal factors, very commonly PCOS, hypothyroidism, perimenopause, menopause, aging. We know that that can tend to decrease in metabolism because we tend to lose muscle mass, and muscle mass is our most potent metabolic organ. Then we go to environmental factors, which involve industrialization, endocrine disrupting chemicals, plastic, forever chemicals that can mimic our own hormones and promote obesity. Then we can talk about food industrialization too, the food industry, right? We consume hyper palatable foods that do change our chemistry in our body and promote obesity. And then the last piece of that equation is lifestyle, what the patient does or doesn't do in regards of movement and what they consume in food.
So we know obesity is multifactorial, and I like that you put lifestyle last because many people just believe it's all about willpower, and obesity as a medical condition is so much more than just willpower.
Definitely.
Problems with willpower. My next question is, can you define what GLP is? And can you tell us, does it decline with age? And so should most of us be putting it back in, if that is the concept?
Let's start with that. There is no GLP-1 deficiency. We are not replacing something that our body doesn't make or stops making or makes in less amount as we age. No. And the studies have been done to show that. The problem with our own GLP-1, and GLP-1 is a hormone, is a gut hormone that is produced in two places in our body, in the small intestine and the L cells, and in the brain also we have where it's produced in the brain. So brain and gut. And the problem with our own hormone is that it's very short-lived. It only has a half-life of 2 to 4 minutes because it's broken down by an enzyme, DPP4 enzyme. So our own GLP-1 is not that it's deficient, is that the half-life is very short. What we have commercially available that we know as Ozempic, Mounjaro, Wegovy are long-acting versions of our own GLP-1. So again, it's not that we don't have, it's not that we're getting more GLP-1, it's that we're getting an engineered version of a GLP-1 that is going to last in our body for a week, as an example of the weekly injections.
And so there are two places we're making GLP-1 hormone, in the gut and in the brain. But where do we have GLP-1 receptors?
So brain, gut, heart, lungs, bone, muscle, pancreas, of course, liver. We are finding more and more places, even thyroid, the thyroid gland also. So we're finding more and more places where there are receptors of GLP-1. And this is one thing that GLP-1 is teaching us, because it has taught us so much that we didn't know in medicine in regards to obesity and weight loss, is that we have receptors in different parts in our body, and receptors can have different functions, right? Depending where it's going to act, this hormone is going to exert a specific function of that organ specifically.
That's incredible. So GLP-1 is made in two different places. It's made in the gut and the brain. But we have GLP-1 receptors all over our bodies. So in our brain, pancreas, gut. And this allows it to have many different functions in different organs. So can you speak a little bit more about GLP-1s beyond weight loss? Because right now everyone's talking about GLP-1s and we're kind of hyper-focused on the weight loss aspect. But what are the other benefits of GLP-1?
And many of the benefits that we're seeing of GLP-1 beyond weight loss, the majority of them are due to the weight loss itself, right? We know that chronic diseases such as type 2 diabetes and obesity can have long-term complications when they're not controlled or treated, right? We know hyperglycemia, it's a huge risk factor for stroke, heart disease, kidney function, fatty liver, right? So by improving the glycemia in patients with type 2 diabetes, we are going to see improvement in other systems. Same with obesity. We know because obesity, there's increased risk of sleep apnea, joint pain, osteoarthritis, fatty liver, hyperinsulinemia, insulin resistance. And we're seeing benefits in every organ that we know could be affected because obesity itself. So all of the studies that we currently have to date are in patients that started with type 2 diabetes and obesity. So all the benefits that are being documented is specifically due to the improvement of these two diseases, type 2 diabetes and obesity. Now, we know that because of the receptors in other organs, we can assume that there's going to be effects that are independent from the weight loss itself and from the controlling the hyperglycemia. We know that GLP-1s do have a direct effect in inflammation, right? And I think that's one of the, for patients, what I see clinically is even in the first week, second week, immediately they start noticing some improvement, even before there is significant weight loss to say that this is due to the weight loss. So I do believe that we're going to see more effects. But I want to bring the attention to something very important that happens the first week and the first 2 weeks of a GLP-1 treatment. Definitely not necessarily weight loss per se that is going to improve. But from the get-go, when somebody starts a GLP-1, almost immediately they decrease their consumption of food to maybe 2/3 of what they were consuming, in some cases half of what they're consuming, right? So you're decreasing the consumption of food, let's say by 30% for the majority of patients. And not only that happens, but because we have receptors in the brain for this hormone, in the reward system place, the hedonistic eating and drinking, not only are we decreasing the consumption of food, but we're also decreasing the consumption of food that are pro-inflammatory, because that's the hyper-palatable food that has a reward for somebody, right? So the seeking reward from food usually comes from salt, sugar, and fats, which are all pro-inflammatory. So my theory, by doing this more than a decade, is that we see significant improvement in our health just by decreasing of what we consume and by decreasing the consumption of pro-inflammatory food.
So some of the first things my patients say when they start a GLP-1 agonist like tirzepatide or semaglutide is they have decrease in brain fog. That food noise is shutting down. They feel like they can focus on certain tasks and they're not constantly having to think about food. They feel like they're getting sick less and less than compared to before. Have you seen these other side effects that go beyond weight loss in your patients?
And I just want to say that it makes me really sad as a physician, and it brings me a lot of shame as a physician that we were not aware of the mental load of our patients trying to lose weight. And I learned that through my patients, having the time to listen to them. And to my surprise, and this I learned through them, not in my medical training, not in my specialty, not even when I became obesity board certified, is patient after patient coming and telling me, I'm eating less, I'm exercising more, I'm trying even harder, but it's not happening. To know that patients were actually doing everything that we were asking and beyond, adding more of the mental load of their guilt and shame of their weight. So when we have a patient with, and I have many patients that have been decades in that situation, right? That is a 24/7 mental consumption of their weight and their plate in front of them. When you put them on a medication like a GLP-1, it changes their life. They become lighter, right? They become lighter not just in weight, but in guilt and pressure and shame. And that's one of the reasons that I wrote my book, is because when I started hearing my patients coming back, teaching me about diets that I've never heard before because they've been following everything to the T, I had to make other people know. My colleagues, doctors, this is what our patients are doing. They're actually listening to us. But we go back to the willpower bias idea that we have, right? That it falls into the patient's responsibility of the weight loss, when we now know that is their responsibility is a very small puzzle of the equation.
I agree. I was actually at dinner with one of my friends, and she was like, one of the best parts of starting a GLP-1 agonist like semaglutide and tirzepatide was that she didn't have that food noise anymore. She no longer was worried about how is she going to lose weight, what should she be eating. She didn't have to have all that mental burden that she had before. She felt so much lighter, like you said, from not having to carry that mental burden and that food noise with her everywhere she went. She was able to focus on the task at hand instead of constantly being sidetracked by all that food noise.
Yeah. And I can say that that's something that, another thing that GLP-1 medications are teaching us, right, is that patients carry this mental load besides their physical load, right, with obesity. And what I'm seeing a lot too is that it's opening another door or another Pandora box, treating patients for many patients, it's the first time that they are in a goal weight in their life. For many patients, it's the first time that they see themselves in a healthy goal weight. That is also carries a lot of psychological guidance that at the moment we are not being fair to our patients, because we as doctors, we concentrate on a number. We have to get you to the number, a result. But we're not also caring about the mental changes that are happening in patients as they're losing weight. So what I foresee is that we're going to have to do parallel treatment for the physical weight, but also for the mental weight. So we get our patients to not just a physical goal, but at a mental goal, because their psyche is not catching up as fast as the weight loss is happening. And we're not being fair to our patients, but just treat the physical weight, but not the emotional weight also.
So I think the future holds a place where we'll not only be taking care of them when it comes to their physical health, but when you're putting somebody on a GLP-1, there's a huge mental component that currently I think many physicians are ignoring.
The majority.
Right. And there's a large place for that to happen, for us to go in there and say there's a mental component and we need to be addressing that mental component as well. And you're right. And there needs to be a roadmap for that mental component. My next question is, many people don't know the different options they have of GLP-1 agonists. Can you kind of just briefly go through the options that we have, from compounded and to the brand names, and what the difference is?
Yeah, definitely. I like to simplify as an example and say GLP-1s are like the iPhone, right? We have the iPhone 8, which could be Saxenda, Victoza, liraglutide. Then we have the iPhone 12, which is semaglutide, Ozempic, Wegovy. Then the iPhone 14, which is tirzepatide. And then the iPhone 17 is coming, and the iPhone 18. It's on the same concept, but every time they get better, safer, and more effective. So that's an easy way to see the different medications that we have, right? Definitely, as the newer versions come, they learn from the past. As the iPhone, they give more battery life, less bugs. Same with GLP-1. So more tolerability with the newer versions, right? Less gastric side effects that we can see with older versions. More effective, where we're seeing more significant weight loss. Now, if somebody asks me, what is the best drug out there for me? I'm going to say the one that you can afford, right? If it's going to be the one that your insurance covers or the one that you can pay out of pocket that you can afford long term, right? Because this is a long term treatment. This is not let me get you here and then figure it out on your own, because then we're going back to the same stigma that is going to be in the patient responsibility to maintain the weight loss, which we know that didn't cause it to begin with, right? So that's how we can see the medications in regards to accessibility, is which one do you have access to, and that's going to be the best drug for you. All of them still have effects. Again, older versions may have more side effects. So also if somebody is on semaglutide and they're not tolerating the nausea, then that's a good reason to switch them to tirzepatide. But if I have a patient that money is not an issue, insurance is not an issue, I would choose tirzepatide, right? Because it's the best that we have right now in regards to less side effects and more effective.
I love that. Very, very nicely explained. Define the compounded versions then. What is compounded semaglutide and tirzepatide, and how does it differ than the branded ones that are made by Eli Lilly and Novo Nordisk?
And before we go into that, it's many times when we talk about FDA-approved drugs, it's not that we have a relationship with the pharmaceuticals. It's not that I don't get any payback from Novo Nordisk or Eli Lilly, but it's safety. It's what is safer, right? And for my patients, I'm always going to choose what is safer. And what is safer is what's heavily regulated. And what's heavily regulated are the branded FDA-approved drugs. So that's the main difference, right? Is the regulation beyond a drug getting approved and manufactured. Safety. Compounded medications came a few years back when there was shortages of the branded drugs, specifically semaglutide, and there was a permission to compound, to mimic, to reproduce the branded version while there was a shortage of the drug for more people to have access to it. It's been probably close to a year that there's no shortage of either semaglutide or tirzepatide. So actually it's not legal to sell or manufacture these branded versions. What compounded pharmacies do to get in the crack of the situation of this legal requirement is add something different to the formula. Some compounded can add vitamin B12. Some compounded can add a vitamin or something different to be able to legally compound it. The other option was because of price, right? The compounded medications was much less expensive than the branded name. First, I want to say safety should not be where you cut cost, right? Safety should not, because what can be less expensive now, you have a complication, you end up in the hospital, is going to become more expensive than you started. Most medications right now are sold a lower cost when you buy them directly from the pharmacy, and the consumer cannot buy it directly. The prescription that the physician or the healthcare provider is going to go directly to a pharmacy from the pharmaceuticals and then provide it to the patient. That is much less expensive. It cuts the cost about by half. Both pharmaceuticals also have manufacturing coupons. If you have a commercial insurance and it's not covered, they're going to decrease the price also by half. And most recently, this last week, we have an announcement from the government that they're going to offer the medications even at a much less expensive price. So access is really, for branded medication, is becoming more wide.
And I think that's great. I think that we have compounded versions that don't have the same regulatory measures that the branded versions like Zepbound, Mounjaro, Ozempic, and Wegovy have. And to be able to get a compounded version, you're saying it needs to be added with something like B12 or niacin, and that is how people are able to sell the compounded versions. You were able to get the compounded version before because there was a shortage of the brand, and that is when it was okay to get the compounded versions. Pharmacies were given the okay to sell a compounded version, and there didn't need to be an additive like B12 or niacin or anything. But now that we don't have a shortage, we're able to get the branded version. And so if possible, people should be opting for the branded version.
Yeah. And also I would say another thing in compounded medication is most likely board-certified endocrinologist, obesity board-certified physician, or anybody who has a long experience with these drugs is going to prescribe a compounded medication. So I think it's just not it's not safe, 100% safe, a compounded medication, but also probably the supervision or the guidance that you're getting is not the optimal that you need.
And I think that's an important point to make, that if you are going to go for a GLP-1 agonist, it's important to have appropriate guidance under a physician supervision. So that gets me to my next question is, what are the common side effects that people see with GLP-1 agonists, and what is a solution for those side effects?
Definitely. With the older versions, if we're talking about Victoza, Saxenda, Ozempic, Wegovy, we're going to see nausea. Nausea is very common in patients, especially when starting the first few weeks of starting the medication. For some patients, the nausea can be limiting, that they may have to stay home, and it should not be like that. Also, diarrhea. Diarrhea is very common in all the generations of this hormone, because anything that the patient will consume that is processed or fried or heavily in fat, even avocado or too much nuts. So it could be also the good fats, but anything that is high in fat can cause diarrhea with any of the versions of GLP-1 that we have. Muscle loss, we can see that as an indirect side effect, right? There is nothing in the hormone that goes to the receptor or to the muscle fibers and causes muscle loss. It's more of a decrease of caloric intake and more of a decrease of protein intake when you start using a GLP-1. Hair loss is another side effect that is concerning for many people. And I always see hair loss along with muscle loss, or muscle loss with hair loss, because it comes from the same macronutrient, which is protein. So if you're not getting enough protein in your diet, you're not making collagen, you're not making elastin, and you're going to lose muscle mass.
My next question for you is going to be all great points that you made, is that what do you have any long-term concerns? I think the biggest challenge I see many people who are against taking a GLP-1 agonist, who may benefit from a GLP-1 agonist, but who don't want to take it, is they're afraid of the long-term consequences. In 15 years, we'll figure out this was a side effect, so I don't want to take it. What do you say to those patients?
I would say that what if should not be the reason to stop you from using a GLP-1 medication. And I can say that the majority, if not all of them, patients that may come with that concern, never want to stop the drug, right, because of the benefits that they see. But in regards to data, the first FDA-approved GLP-1 was in 2005. So clinically, we've been using it in patients for 20 years now. But as you know, any medication that is going to be approved has a few years behind it being researched and studied. So we have close to 30 years of data of safety of GLP-1 medications. They're not new drugs. Again, we have 20 years using them in clinical settings with patients. Now, the complications of obesity and the complications of uncontrolled type 2 diabetes, those really are more something that somebody should be concerned if they're not treating their diabetes or their obesity.
People say GLP-1 agonist is a new drug, but it's not a new drug. According to what you just said, GLP-1s have been around for 30 years. We have 30 years of safety data on this drug. So if people are worried about, hey, it hasn't been around for a long time, that's actually inaccurate. It has been around for a long time, and we do have a safety data on it. So if you need it, your recommendation is you should take it. If your doctor said you should take it, you should be taking it.
Yeah,
I love that.
I would say, as a patient, you have the responsibility to do a little bit of research from where you're going to get the medication, right? Because I do believe that who is going to guide you in this journey is going to be the reason that you're going to have success on it, or the reason that you are going to be miserable on it. So choose wisely.
Great. I love that too. My next question is, so GLP-1s not only help with type 2 diabetes and weight loss, but they have other benefits. For example, they may decrease risk of cancer. They have cardiovascular benefits. Can you elaborate on those?
Yeah, definitely. So we go back to inflammation, right? So when somebody has obesity, and let's redefine what obesity is, right, in regards to a diagnosis. BMI, we know the BMI is an outdated tool from the 1800s that it was based in white European men. We move beyond that, now we can diagnose obesity in different ways, ideally with a body composition, right? So having high visceral fat, having percentage body fat above 32% for women and above 22% for men, that's considered overweight, and then higher numbers will be obesity. What in somebody's weight will make them a risk of disease? Visceral fat and low muscle mass. Visceral fat, why? Because visceral fat is an active tissue that is producing cytokines that are pro-inflammatory chemicals that put your body in chronic inflammation. Chronic inflammation, what it means is that your immune system that is built to protect you from harm, either a bacteria, either a virus, or tumor cells, or antibodies, or autoantibodies, our immune system, when it's free, it protects us and it does its job. But if you have your body in chronic inflammation, all your immune system is preoccupied treating and combating that pro-inflammatory tissue in visceral fat. So it's leaving the door open for other hazard, dangerous things in your body to come in, including tumor cells to grow. So by decreasing inflammation, by decreasing visceral fat, your immune system is going to do its job, and you may be protected from all the hazards, the things that I mentioned, bacteria, virus, and COVID is a perfect example. COVID came to show us that people with obesity were in a chronic inflammatory state because came this virus out of nowhere unexpectedly, and patients with obesity were the ones with higher mortality or having more of a severe disease.
GLP-1 agonists not only help you lose the weight, decrease your risk of type 2 diabetes. They're actually a treatment for type 2 diabetes, but they actually decrease the risk of cancers. In fact, I think a study found 10 out of 13 cancers had a decrease in risk on people who were on tirzepatide. And people were also seeing cardiovascular benefits, decrease in blood pressure. It was better for their kidney health.
Kidney function,
It was
liver
better for
function.
their kidney function, liver function, fatty liver disease. So what are some of the FDA-approved indications for giving a patient GLP-1?
So currently we have type 2 diabetes, obesity, or overweight, which unfortunately is still using the BMI, but it will be a BMI of 27 or above with one comorbidity. You meet criteria there for a GLP-1, or a BMI equal or greater than 30 with or without a comorbidity. Also, we have indication for cardiovascular, decreased risk of cardiovascular disease, sleep apnea, and improved kidney function too. But these indications also are in patients that have type 2 diabetes and or obesity.
What about fatty liver disease?
Also for fatty liver disease.
So fatty liver disease, sleep apnea.
Decreased cardiovascular risk.
And what does that mean? What does decreased cardiovascular risk? So for the patient, they want to know, do I qualify for a GLP-1 agonist? So what would they need to have as a medical condition, as a medical diagnosis for them to qualify to get a GLP-1?
Sleep apnea, number one. High risk of cardiovascular disease, and this could be, hypertension, hypercholesterolemia, or past history of a cardiovascular event. And fatty liver, documented fatty liver. But those are also the other indications that we have for the medication.
So GLP-1 agonists could be used for people who not only have type 2 diabetes and are classified as overweight and obese based on their BMI, but there are other conditions, which tells me that many physicians should be asking, do you snore? Because if you do snore, one important test that I personally get on a lot of my patients is a sleep apnea test, because that could be an indication that they could benefit from a GLP-1 agonist. So if you are snoring, if you're snoring frequently, if you're routinely snoring, get a sleep apnea test, because that could help you understand if you are a candidate for a GLP-1 agonist.
Yeah, many times we get the authorization of the medication through a different diagnosis and not necessarily diabetes or obesity.
And that's important for people to know. You want to go to your doctor and have these conversations that, I am snoring. Can we get a sleep apnea test? Because if I have sleep apnea, I may qualify for a GLP-1 agonist. And sleep is probably one of the most important markers
Yeah.
for our longevity.
I think, like, to give an example, if somebody has obesity and sleep apnea and the medication was not approved by your insurance, or they don't want to pay it for obesity, they may pay it for sleep apnea, although we know that the sleep apnea may be related to obesity, right? The insurance will pay for either diagnosis, but not both or three diagnoses, right? So if they deny it for one diagnosis, it's worth to try for a different diagnosis that may increase your chances of getting the medication approved.
Do you have any contraindications for GLP-1 agonists?
So we have two absolute contraindications of a GLP-1. One is if the person has personal in themselves history of medullary thyroid carcinoma, which is a very rare type of thyroid cancer and also very aggressive and usually runs in families, or MEN, which is multiple endocrine neoplasia, because also increases the risk for medullary thyroid carcinoma. But any other type of thyroid cancer, and I get this question a lot, if it's papillary, if it's follicular, it's a Hürthle cell, it's okay. There's no contraindication. Of thyroid nodules is not a contraindication. So absolute contraindications, medullary thyroid carcinoma, MEN. Now, I would not prescribe this medication for somebody who has history of anorexia nervosa. That's one. History of pancreatitis due to a GLP-1. Also, I most likely would not recommend a GLP-1 medication, but pretty much from that, anybody else can be a candidate for a GLP-1.
What about somebody who is breastfeeding or wants to get pregnant?
So we don't proactively recommend a GLP-1 medication in pregnancy, although I foresee that we will use it one day for gestational diabetes. I think that's going to be a very important use in women. We have patients that ended up getting pregnant while on a GLP-1, right? We even heard the term Ozempic babies, because decreasing in weight loss increases fertility, decreasing inflammation increases fertility. So many patients that thought they couldn't get pregnant naturally by being on a GLP-1, surprise, surprise, they ended up getting pregnant. What happens in those patients is that we stop the medication and they have continued to have normal pregnancies. As we know, we don't actively test pregnant women with medication, so I think most of the data is going to be retrospective and more clinical information that we get through the years. Breastfeeding, so the injectable GLP-1, it's subcutaneous. It doesn't go through the gut in the mothers, so unlikely that it's going to come through the breast milk. And also, the molecule of the GLP-1 is larger than the mammalian ducts where the milk comes from. So also unlikely that it's going to go through the duct. And if it does, it may be eliminated or broken down by the stomach acid of the baby once it goes in the mouth. With oral GLP-1, I think that's going to be different. I think there's going to be more risk of transfer from the breastfeeding.
So that's actually great news for many postpartum mothers who are battling the weight gain, who are struggling with weight loss. There may be an opportunity in the future to use GLP-1s, you're saying, with breastfeeding. And I think that is huge.
Maybe.
But
it's not a no. I think there
is some room.
There will be room for it.
That's important. So you defined, or I'm going to ask you, I hear this term around a lot. I hear this a lot. Ozempic baby. What is that term? And can a GLP-1 agonist potentially have a role in fertility? Can it help people potentially get pregnant?
Well, definitely. And again, this is just to show us all the complications that are caused by obesity and or overweight for some women, right? We know that obesity causes infertility. And we know by decreasing obesity, infertility increases. So thinking of a GLP-1 as treatment for obesity, yes, is going to improve the chances of fertility for women and men, right? So you can potentially get pregnant while or because of a GLP-1. Also, GLP-1 decreases inflammation, and we know inflammation can also cause infertility. PCOS, right, which is a hyperandrogenemic syndrome, and not so much that there's follicles or cysts in the ovaries, is more the hormonal changes that happens in PCOS. GLP-1 medications improve also PCOS, and PCOS is the number one cause of infertility in women in the United States. So by improving that, then we're also improving fertility, right? So there's different pathways that decreasing body weight, decreasing inflammation with a GLP-1 can improve or increase your risk of fertility.
And along those same lines, can a GLP-1 agonist reduce the risk of cancer?
Definitely. By reducing the risk, by reducing inflammation in the body, you're going to have a decrease in the risk of cancer. We know breast, prostate, colon, thyroid, stomach, esophageal, pancreatic cancer, liver are all related to obesity, or obesity increases the risk of this type of cancers. So by treating obesity, you're reducing the risk of all these cancers. I predict that in the next 2-3 generations, it may not be in our lifetime, but for the future generations, we're going to have less incidence of these types of cancers, less incidence of chronic disease, less incidence of type 2 diabetes, which that is going to, to think of all the complications that we've built medical specialties around the complications of obesity and overweight, that's going to improve.
I love that. Now, let's go through dosing a bit. There are a lot of people who just want to jump to the higher dose. They don't see anything happening on 2.5, 0.25, so they just want to jump. How would you recommend dosing of GLP-1s? Is it that incremental stepwise? Do you go a little faster in some people? And tell me your thoughts on people who are like, you know what, I'm on the highest dose and I'm not losing weight.
So definitely everybody's different. Everybody, every human is an individual, and they may require different dosing or different rate and change of dosing, right? So my first advice would be, don't compare your journey to your wife, your daughter, your friend. Each journey is going to be individual. Each side effects may be very individual too. So the dosing of semaglutide, which is Ozempic and Wegovy, starts at 0.25 milligram, and that's recommended for 1 month. The 0.25 milligram is not a dose that we're going to see significant weight loss. That's for semaglutide. So 4 weeks on 0.25. And don't skip this dose, because if you do this dose and you tolerate it, it's going to allow you to tolerate higher doses where we see more significant weight loss. So this dose it has a reasoning that it's there. Even though you're not going to see significant weight loss, it's doing something. Trust the process. And then on week 5, you can move to the 0.5 milligram dose in semaglutide. And then I like to say that each dose has about a 3-month expiration period. We get about 3 months of effect on each dose. Tirzepatide, which is Mounjaro and Zepbound, is a little bit different. The first dose, which is 2.5 milligram, is a therapeutic dose. We can see, and I've seen patients lose up to 30 pounds, even on the first dose. So in that dose, in tirzepatide, the 2.5, you can stay up to 3 months. Some patients can stay up to 6 months because it's a real dose. Again, after 3 months, most likely you're going to need to be changing your dose. A good way to know when to increase your dose is if the effect of the once-a-week injection is not lasting you the whole week, right? That on day 5, on day 6, you're like, oh, I finished my plate. I'm thinking again on food. Maybe I should use it every 5 days. No, that's the time that we need to go up to the next dose.
That's important to know. My next question is, okay, so you have a patient, they're on the highest dose, they still have 20 more pounds to go. What's the next step?
So that's another reason why we should not jump into doses very quickly, because then we're going to reach halfway your goal and then we have nowhere to go. So we really need to maximize each dose, especially if your journey and weight loss is significant, right? If we're talking about 50 pounds, 60 pounds, 80 pounds, 100 pounds, we should really try to maximize each dose, because you're going to get at the end with still a lot to go and no doses to go anymore, right? So that's another reason why we should slow and try to maximize each dose. If we need to do body compositions on patients before starting a GLP-1 and every follow-up visit, ideally we should do a body composition. So to truly know if the patient is really not losing weight, right? Because maybe the patient is gaining muscle, but the body fat is coming down. And if they see it reflected in the scale, they won't see a big change, but their body is having a body recomposition, which is what we're looking for. So first of all, make sure that you're truly not losing weight. If you're not losing weight and you're already on the max dose, there's something that we can also do, and this I do in my patients, and this is reserved for my patients, but I'm gonna share it with you. There's another drug that I use in combination with GLP-1, an FDA approved weight loss drug. that it's named Quisemia, which is a combination of phentermine and topiramate. So for my patients, what I do when I have a patient that has significant amount of weight loss, and I'm not talking about 20 pounds, I'm not talking about 30 pounds, but above that, I use combination therapy. I do the GLP-1 medication, and then I use the oral medication, which is Quisemia, which I mentioned is a combination of phentermine and topiramate, which increases your metabolism, and it also has a little bit of appetite suppression. Using Quisemia with a GLP-1 buys me more time on each dose of a GLP-1, especially, again, when the journey is a long one in regards to the amount of weight that needs to be lost. So if you have somebody who you max on the medication and you still not reach the goal, you could potentially also add to the treatment an oral drug, which is Quisemia. But this is going to fall back in the expertise of the doctor, right, and seeing and treating significant amount of patients in order to feel comfortable in doing this combination cocktail for weight loss.
I absolutely agree with you, and I love that you said trust the process. There's so many people who come to me and was like, can I just jump to the next dose? Can I jump to the next dose? The answer is likely like, no, we got to get on this dose for at least 4 weeks. Let your body get used to it. See the side effects. Because if you jump too quickly, you're exactly right. When you get to the end and you still have more weight to lose, there's nowhere else to go. So I think that's a really, really important part that you said. And each person has its own personalized journey. Stop comparing yourself to your friend, to the Instagram influencer that you're following. This is your journey. Have a conversation with your physician, and stepwise approach is key. And I 100% agree with that. Now, let's turn a little bit to nutrition. I'm always telling my patients, don't forget about the 40 grams of fiber. Make sure you're getting enough protein intake. But what's often forgotten is hydration. If you don't feel like eating, you likely probably don't feel like drinking.
Exactly.
Drinking water is what I mean. So hydration is key. So how do you have that conversation with your patients? What are important nutrients you are recommending to people who are on GLP-1 agonists?
So my process with my patients, I like to, and then this is part of my book, and in my book I describe it as the GPS. Your GPS, your navigation system in this journey. G is for GLP-1, P is for protein, and S is going to be for strength training, right? So on your first appointment, you cannot leave with a GLP-1 prescription without having a conversation about nutrition. And that's what I would say myself, we were doing way at the beginning, prescribing this medication. We were not having a discussion of nutrition, and patients were losing muscle, right? And before that, we were not doing body compositions. We were not even aware that patients were losing muscle. And that's a problem, because when patients lose muscle, they lose that burning fat for energy machine. Muscle consumes 80% of the glucose in our blood, and muscle produces hormones. Produces myokines, which are anti-inflammatory. So we were robbing patients from this for muscle mass. But we've learned through the years by doing body compositions, we can prevent muscle loss. And in fact, patients can gain muscle while on a GLP-1 losing fat. But this is going to be with the proper nutrition. So protein is going to be the most important macronutrient. And protein, to say to everybody, is not a fad. It's not something new. It's not that we're just learning about protein. We've known that protein is important for decades. But again, thanks to GLP-1, it's bringing more attention now. It's bringing more attention to strength training. So protein definitely is important. Hydration, as you mentioned. And I would say that most patients that complain of feeling fatigue with a GLP-1, it's not hypoglycemia. It's not that your sugar is low. It's not that you're not consuming enough calories. It's going to be 9 out of 10 times dehydration. So proactively hydrate yourself. I like to recommend about 1.5 liters to 2 liters of water per day. You should be urinating every 3 hours to know that you're well hydrated. And then fiber, right? Because these medications, especially semaglutide, liraglutide, can constipate as a side effect. I see much less constipation in tirzepatide. So also increasing fiber in the diet is going to be important.
How much protein are you recommending for your patient?
I recommend about 1 gram per pound for ideal body weight, right? So if in your first appointment is determined that your ideal body weight through a body composition, right? Not through BMI, through a body composition. Let's say your ideal weight is 140 pounds, depending on your height, depending on your sex, right? I'm just giving here a broad example. Then around 100 to 140 grams of protein a day would be ideal to prevent muscle loss. It's not easy, right? It's not easy to get, even without a GLP-1, to get that amount of protein. It's difficult. So what I found clinically doing thousands of body composition is for women, around 90 to 100 grams of protein. I see very minimal muscle loss. And I can see muscle gain if we add strength training to the equation. For men, depending on their height, it's probably going to be more than the 100 grams of protein per day. The easiest way that I found for patients to break it down to be able to consume 100 grams of protein per day is to break it in 4 portions. 4 portions of 25 to 30 each portion. It's going to be hard to eat 4 meals of 25 to 30 grams while you are on an appetite suppressant medication. So we are going to have to rely on supplements of protein. And this is while the patient is on this treatment, right? It's a medical treatment that you're going to require medical guidance that you may need supplementation of protein to prevent muscle loss. It's okay. It's a medical treatment. Let's remember that, right?
Yes.
So what I find easy for patients is 1 protein shake that has 25 to 30 grams, then meal, and then another shake, or 3 meals, 1 shake, or sometimes 3 shakes, 1 meal, right? It's going to be alternating depending on the day of the patient.
I love that. So we want to make sure we're getting enough hydration where you're urinating every 3 hours. We want to make sure that we're eating enough fiber. I say 40 grams of fiber. I'm not sure if you're there.
I mean, 25 to 40. It's
25 to 40 grams of fiber. And you want to be eating 1 gram per pound of ideal body weight of protein. And that may require many people to take a protein supplement in the form of a bar, shake, or powder. Are there any other supplements that you recommend? I hear many people saying if you're on a GLP-1, you should consider multivitamin because you may not be eating enough, so you may become deficient in nutrition. What are your thoughts on GLP-1 agonists and certain supplements people need to be taking or should be taking?
This is the reality of this medication. Just because you're on a GLP-1 doesn't mean that you can eat whatever you want, right?
Bingo.
And I would say for the majority of patients, it happens very automatically because the bad foods, the hyperpalatable foods, are usually the ones that we associate with a reward, and this medication is already blocking that. So for many patients, it becomes very natural to avoid this type of food. But some patients were not explained, right? I won't blame the patient. I will blame the healthcare provider that didn't guide the patient or give them the right information. If you are eating, let's say, French fries and pizza just in less amount, then yeah, you're not going to have all the nutrients that you probably didn't have the nutrients to begin with, even beyond the GLP-1 if you're having that diet, right? But if you get the proper guidance and you follow through by increasing protein in your diet, and animal protein, let's say, or in tofu or in soy, you are eating fats with that protein, right? Fiber, you should have fiber, as we mentioned. But I've never seen any nutritional deficiencies as we would see with bariatric surgery, right? Because, and that's another important reason why you should not be on a high dose that you are not prepared to be, or that is completely eliminating your appetite. Fast weight loss is not the winner in this situation. It's actually the loser. So we don't want rapid, fast, significant weight loss because it means that you're really not consuming enough calories. You'll be losing muscle mass, and you're not getting the proper nutrition. But for the majority of patients, they do get enough nutrition without the need of replacing any other vitamin. Vitamin D is a very common deficiency, not related to GLP-1 medications, related more to obesity because it's more square meter surface that needs the vitamin D. So supplementation of vitamin D is common in patients with obesity, but not due to being on a GLP-1 medication.
And what if you're on a GLP-1 and you have hair loss? What do you recommend to do?
If you're on a GLP-1 and you're having hair loss, I have to break it to you, you're also losing muscle. And if you're losing muscle, you're also losing hair. They go together. Why? Because under the same macronutrient fundamentally, which is protein. We need protein to make collagen and elastin, right, which is needed for hair growth, for our skin not to sag, right, to avoid Ozempic face, Ozempic hair, is the protein in your diet. If you're not losing muscle, I can guarantee you won't lose hair.
Wow. So protein seems to be the winner. One thing I also check in my patients, lab-wise, is ferritin, is making sure they're also getting enough iron, because a ferritin below a certain value may actually also cause hair loss. So I love the protein conversation. And this kind of leads me to my next conversation. Are there particular labs that you get before starting somebody on a GLP-1? And how frequently do you repeat those labs?
So I do a complete panel of blood work, not to guide me if the patient needs or not the medication. That decision is made before any blood work is done, right? It's more to see, okay, where am I starting with and what do I need to follow? What's going to change once I start on a GLP-1? But really, there's no laboratory number that is going to prevent somebody going on a GLP-1 or make somebody go on a GLP-1. It's more just to see what changes are we planning to expect to see with a GLP-1. You mentioned ferritin. I do feel that ferritin, especially in women,
right,
either in their fertile years or in perimenopause and menopause, just because of our menstrual periods, we can tend to have low ferritin, and low ferritin will cause hair loss. So yes, if you have a woman on a GLP-1 and is complaining of hair loss, definitely test for ferritin.
I like that. Some labs that I particularly love testing before I start somebody on a GLP-1, just to get a baseline, is going to be their hemoglobin A1C. I get a fasting insulin, fasting glucose. I want to know what their lipid panel is, what their apolipoprotein B is. I want to know their AST, ALT. Do they have signs of fatty liver? We want to track that. We want to see if that's getting better when you're on the drug. I also test hormones in certain patients. Are you in perimenopause? Because pairing your GLP-1 with an HRT, you're going to see benefits in both, in the weight loss and in some of your symptoms of perimenopause as the weight starts coming off. So I love pairing those together. So I do sometimes get lab work. Not necessarily exactly like you said, do they need to start the medication, or the lab work is not going to determine whether they need to start the medication. But the lab work will definitely guide the journey. I personally like to do lab work every 3 months in some of my patients, at least every 3 months. Is that where you're at, probably?
Yeah, especially if I'm following a certain value like the A1C, if I want to see improvement on the A1C or the cholesterol before I make a decision of starting on a different medication on the patient, right?
And like you mentioned, one thing that a few tests that I do before I start people on a GLP-1 agonist is a body composition. That is definitely going to guide me in showing them their visceral fat, their muscle, and as they're on the drug, how much protein are you getting? Let's see if we need to up that strength training. Let's see if we need to up the protein intake. I do sleep apnea testing on many of my patients. If you want to lose weight on a GLP-1 agonist, let's do it right. Let's optimize all facets of health. So if you have sleep apnea, if you're snoring, you will probably lose more weight if we correct that while we start you on a GLP-1.
Definitely. Sleep. If you're not sleeping, if the patient is not sleeping, we're never going to maximize the benefits from a GLP-1 medication.
Bingo. I agree.
If there's one symptom that that is like a personal goal to improve in my patients is sleep. Because if you're not sleeping, nothing is going to be enough. Nothing that we do is going to be enough.
Right. So we get the lab work. We then get a body composition scan. I also like to know if they're sleeping, snoring, get a sleep apnea testing on certain patients of mine if they are snoring. So these are just a few of the testing that we do before we start them. And some of them we repeat, like a body composition test, like you said. I think it's great to do it as frequently as possible. And some of my patients, we do it once a month, once every few months, when they come to see us. And having those regular check-ins with your physician is also very important. When is it time to increase my dose? When is it time to stay on the same dose? And I think you do need to have that conversation with your physician when you are doing. My last question is going to be, what is microdosing of a GLP-1? What is microdosing and what are some of the benefits?
So the definition of microdosing is getting a lower dose than what we currently have available, right? So in semaglutide will be a dose lower than 0.25. And there's a lot of confusion. I see people say, oh, I microdose. And when I ask what's the dose, they're in the regular dose. So they're not microdosing. You're just on the lowest dose, but that's not microdosing. So microdosing is even below the initial drugs that we have, which is 0.25 in semaglutide and below 2.5 on tirzepatide. Now, microdosing I think it started from the side effects, right? I feel like many people, when started prescribing this medication, that didn't have the proper training, didn't know how to guide patients through the side effects. And the thought of, okay, if I give you a lower dose, then you're going to have lower side effects. But the reality is that at the 0.25 milligrams semaglutide and 2.5 milligram, the side effects are completely manageable for the majority of patients if you're getting the medication through the right provider, right? Otherwise, they don't know how to guide you, and you're going to have side effects at any dose. So that was the initial thinking, is less side effects. The second thinking is more, well, I want to get the benefits from a GLP-1, but I don't need to lose the weight, but I don't have diabetes, so I'm going to use a lower dose. Now, before we can say that somebody doesn't need to lose weight and just wants the anti-inflammatory benefits or the longevity benefits, I need a body composition. I need a body composition to see that you truly won't benefit from the real effects of a GLP-1, which is decrease in visceral fat, decrease in food consumption, right? If you have high visceral fat, you're benefiting because of the visceral fat loss from a GLP-1. If you have a healthy body composition, which will be percentage body fat less than 28 in women, less than 20% in men, very low visceral fat, and high muscle mass, I can guarantee you're already getting all the benefits that you can think you're going to get from a GLP-1. Because having a healthy body composition still matters.
Right.
You're getting all the goods from having a high muscle mass and low visceral fat that you can potentially get from a GLP-1 medication. And I think that's really important to mention. Also, GLP-1 is not a supplement, right? It's a medication, a medical treatment that requires supervision. When we think of microdosing, we don't see it as a medication anymore, right? We are a little bit more laid back with the supervision of the medication, and it's still a medication, right? So if you don't really need the weight loss or glycemic control benefits of a GLP-1, and you have a very healthy body composition, and you have a healthy lifestyle, I would say rest assured that still has value.
Do you have to be on a GLP-1 forever after you start? Is there a way to come off of a GLP-1 medication? Or once you're on it for life?
The $60 million question. And I like to respond, I like to throw it back to the patient and say, whatever was the reason that took you to need a GLP-1 is going to determine if you're going to need the medication long-term or not. If I have a patient in midlife, as an example, and they've struggled with weight since childhood, right? If this is something that they've carried through decades, most likely you will benefit from long-term use of the medication for also weight loss maintenance, right? Because your obesity or your overweight is not due to your lifestyle choices. It's broader than that. If you're somebody, I'm going to use as an example myself. I got pregnant in my late 30s, early 40s. Then I hit perimenopause. I carried 40 pounds that I never carried before. I never struggled with weight. I was always physical active with strength training and high protein in my diet. But my environment and circumstances were different than pre-kids and perimenopause. I couldn't lose the weight. I used the GLP-1 for about 6 months, got back to my weight, and I haven't needed it since I used it. So this is years now, right? So it's going to depend a lot on the reason that you needed the medication to begin with. But I like to flip it and say, for the first time, we have something, a treatment that is going to help you maintain the weight loss, and that is huge. And I think we should concentrate on that benefit and that gift from this medication, is that we can use them long-term, that they're safe to use long-term, and that is the only thing that we currently have that also helps with weight loss maintenance.
So what I'm hearing you say is that And I agree. I agree with you because I see this with my patients all the time. There are some people I can get off of the GLP-1 agonist, but there are plenty of people who are going to need to take it for lifelong. And the reason of how you're going to fall into the category, we can come off of it and maintain the weight loss, or you're going to have to stay on it to maintain the weight loss, really depends on the reason you got on the GLP-1 in the first place. And I think that's really, really important to note here. With that said, there are plenty of people who we don't, I'm not sure how you dose it, but there are plenty of people who no longer need it once a week. There are people who we dose them once every 2 weeks. They may need it once every 10 days. And that's maybe how you come off of it.
Here is where I think microdose will and has a play for maintenance. Because let's say I have a patient that reached the goal on the 2.5 milligram of tirzepatide. For maintenance, I don't need them to lose any more weight, but I don't want them to gain weight. There, I do use a half a dose of 1.25 milligrams. Some patients I use 1 milligram of tirzepatide, and some patients I may use even less than that. I feel like there, the microdosing is going to be important for the long-term maintenance. For my patients, it's always one drug at the lowest dose possible long-term. That's how maintenance should be.
And when you're taking these patients off of it, do you decrease the dose incrementally, like decrease it week by week? Do you spread it apart every 10 days, every 14 days?
I decrease it as the same speed or rate that I increased it in the patient, right? Because if you have somebody, let's say, in 15 milligram of tirzepatide, the highest dose, and then suddenly you stop it in a week or in 2 weeks, their appetite is going to feel ravenous. So I have to allow the patient gradually to feel a little bit of appetite every 8 weeks, every 3 months. And also depending on their weight. If I lower the dose, but they're still losing and I'm in maintenance, then I'm going to lower it even faster, right? So again, it's very hard to make broad recommendations because every patient is so different and we have to meet them where they are in their lifestyle, right, in their journey. So, but in theory, it should be gradual. As you gradually went up, you gradually come down.
I think that's really important, and I think our listeners probably need to hear that. So once you reach the maximum dose and you've gotten to your goal weight loss, you don't want to just cold turkey stop the next week. There is a process in how you want to come off that medication, and that process is just as important as a process that got you to your weight loss.
Bingo.
I think we want to say that loud and clear for everyone because I see tons of people just cold turkey stop, and then they're right back in the clinic a few months later, and we have to start the process all over again sometimes. So I think that's really, really important to note. And my last question, what are your thoughts on GLP-1 agonists and kids?
So I'll explain. I'll give you a view of my days in my office, right? I have this male patient that is in his late 50s. And doing his first interview, he tells me he's been struggling with weight since he was 8. And I have to tell you, patients remember when they were first made conscious about their weight, even by a doctor or their mother or their father. They will remember that moment that they knew that they needed to lose weight or change how they eat. So let's go back to my patients. He started at childhood having weight issues, having difficulty with weight and being put on diets, being put on fat camps, as some patients call them, which are centers that they make you lose weight in 2-3 weeks, right? They've carried this struggle in their teens, in their 20s, in their 30s, in their 40s, in their 50s, and they're still struggling. If we can relieve a child or a teenager from carrying years of struggle, why wouldn't we, right? And then we go to the physical complications. If we start with obesity in early childhood, then the complications that we associate to obesity are going to happen in his early adulthood, in their 20s, right? We have patients that they're 10 years old and they have type 2 diabetes. If we can prevent that, why wouldn't we do it? Patients don't have to earn the medication. They don't have to prove themselves that they did the legwork to earn the medication. We have to remove that from our brain as doctors and as patients. You don't have to prove that you need the medication.
I love that. So you are a fan of starting GLP-1 agonist in children when it's FDA approved?
Well, I'm not only fan, it's indicated. So we have FDA approved of Ozempic, Semaglutide for 10 years and above with type 2 diabetes. And we have Wegovy, which is semaglutide. It's approved, FDA approved for 12 years and above for obesity or overweight independent of diabetes. Quizemia, which is the other drug that I mentioned, is also approved for ages 12 and above for obesity or overweight. So it's not just my personal recommendation, it's actually FDA approved for these ages already. And currently, Novo Nordisk is on a phase 2 study using semaglutide in ages 6 to 10 for obesity. Because we have patients that are 6 that have severe obesity. For the drastic problems as is childhood obesity, we need drastic solutions. If somebody can think a GLP-1 is drastic, which I don't.
I think that is going to be game changing. I mean, right now, obesity is so rampant. If we can get this drug to people at a younger age, you're right. I think there's going to be a world where we hopefully will no longer have obesity. We're going to have to end it on that note. Thank you so, so much for being here. I hope our listeners have gained so much knowledge about GLP-1s. I think many of them are physicians. Many of them want to know about GLP-1s. And I think today you've provided valuable information. You do have a book coming out. So
my book is Weightless, and I wrote it with the thinking of my book has heart to begin with. It was very important. Patients will feel validated. Actually, my introduction is an apology letter from me as a doctor to my patients that I misjudged for decades and that they didn't feel validated. So this book is a validation for them, but it's also a complete how-to guide for somebody who is thinking of using a GLP-1, who currently is on a GLP-1, or who even reached their goal on a GLP-1. But I wrote it with evidence-based science for all the practitioners and doctors that want to join this journey of helping patients lose weight. And we need more doctors, right? This is the more, the merrier. But do it responsibly. If you want to prescribe a GLP-1, do it responsibly. And in my book, you will find my clinical experience of how it helped me to help my patients reach their goal.
Thank you, and thank you for everything that you're doing.
Thank you.